idea. Let's pass on to my topic. I'm going to be just dwelling upon certain tips that I routinely practice for hard cataract. And I know several stalwarts are here. And one of the things is a good dilatation is paramount. Otherwise, use some kind of pupil expansion device. Get an adequate rhexis. Usually, it's extremely important that 5.5 to 6 millimeter rhexis. If it's constrained, then the entire thing becomes a little bit of a problem. As already emphasized, a good hydrodissection, and then making sure there's free rotation. And this is actually dispersive viscoelastic that's going in to coat the endothelium. And then I put a little bit of HPMC. This slide is running at 2x speed. And then I make a small trench. And at the depth of the nucleus, I go ahead and bury my phaco tip with an adequate exposure of the phaco tip and do my initial chop. It has to be, you have to make sure, multi-level chopping, as Dr. Vasavada has often emphasized, you need to practice that to make sure that the initial chop that you make is going through and through, and you get a red reflex through. And the number of chops that I create is directly proportional to the hardness of the cataract. Usually I stick to 4 chops, but then in a harder cataract like this, it may be 6 to 8 chops. It's more important that each and every one of them is completely divided, and there is no central core area where there is an addition of the nucleus, and these all should be independent. So all this has happened within the confines of the capsular bag, and I usually use only longitudinal phaco for this. Subsequently, once again dispersive plus HPMC, and now I switched over to only torsional phaco. And as you can see, I keep my phaco needle bent towards the capsular bag, and then subsequently I don't hesitate to refill with viscoelastic as many times as it is needed. My dictum is usually about every 5 seconds of CD I go ahead and refill, especially these hard cataracts. And then you have to always be cognizant of these flying fragments going ahead and hitting the back of the cornea, and that's the nucleus that has come out. You have to be aware that very often these hard cataracts are also have concomitant capsular bag which is unstable, and that is hydroimplantation of the intraocular lens. It's I think a multifocal lens that goes in and works quite well. But I am aware that many of us, I think this is also again a hard cataract, and removal of the whatever cortical material is there. Usually I stick to an intraocular pressure of 30, though the earlier this video was showing something higher. And mind you, at this phase I use only longitudinal phaco, no torsional phaco at this phase. And that's create a small trench, get a hold on the core of the nucleus, then subsequently create that separation. That lateral separation that you do should not be too strenuous, because that itself can put a considerable strain on the capsular bag. And as we discussed earlier, basically some kind of a hybrid between horizontal and torsional horizontal and vertical chop. I bury at the edge of the capsular rhexis and move my chopper towards the area where I've implanted the phaco tip, and at the same time there is a certain amount of lateral separation that takes place. As and when once for the sub chopping, sometimes you can bring the nucleus out and then go to the right to the periphery and then do it. As you can see, that entire, it's essentially slow deliberate movements. The earlier video was running at twice the speed, but this is the actual way I do it, and it has to be done in a very methodical manner. And unless the nucleus is freely rotating, I don't even go ahead and start my phaco chop. And you can see that the amount of energy used within the bag is extremely low, and it's only during the quadrant evacuation that you end up using most of the energy. And intraocular pressure of 30, which translates to a bottle height of about 41, is quite good enough. My settings are not too high, but vacuum is around 600, aspiration is about 32, 34. That gives me good control. And then I refill with dispersive viscoelastic, and then a central bit of HPMC, because the dispersive viscoelastic per se could be thermogenic. And then I just keep the phaco tip centrally placed and allow the fragments to flow into the phaco tip, and it's essentially the fluidics that brings it there, and do the entire maneuver as posteriorly as possible, though I believe that it's not really endocapsular phaco, but it's happening, most of it is happening in the anterior chamber in a posterior plane. Subsequently remove the cortex quite completely. Always be aware of the fact that the haptics might be a little loose. Introduce the intraocular lens, remove the whatever viscoelastic is there left behind, and then stabilize the lens. I know not all of us are completely comfortable with doing a phaco chop in very hard cataracts. I think stop and chop is a great way of dealing with these cataracts. Even now, once I have created the central trench, and if I feel that I am not getting a complete chop, adequate chop, I have no hesitation in going ahead and extending that and converting to a stop and chop. So here the idea is to create a deep central trench of about 1.5 to 2 times the width of your phaco tip. And as you can see over here, it's down up sculpting, and then you can see that I want to thin out the posterior plate as much as possible. Whether it's direct chop or with a stop and chop, the idea is to break the backbone of the nucleus. I go in with 2 Sinskey hooks through the 2 side ports, go into the depth of the central crater that I have created, and gently separate them. And if I feel that I have to exert undue pressure, I don't mind going back in again with the phaco probe and thinning out the plate. It's extremely important that when you are separating this, it has to be 2 complete heminucleus that is made, and at the same time you do not do too extensive lateral separation to stress the capsular bag. And once this is done, you can bring out each of the heminucleus into the anterior chamber, doing the entire procedure as posteriorly as possible. As you can see, most of the energy is consumed during this phase. That is the reason that it's a good idea to use a refill with a viscoelastic, dispersive viscoelastic, especially to coat the endothelium. So what are my dozen pearls for dealing with a hard cataract? Choice of anesthesia: do not hesitate to give a peribulbar anesthesia because the surgery might be long. Make secure long incisions which are not leaky, not only the main port but also the side ports. 5.55 millimeters well-centered rhexis, hydrodissection and rotation so that you break up all corticocapsular adhesions. If you're doing a direct chop, make a mini trench and then bury in your phaco tip. That gives you access to the meat of the nucleus. If it's a stop and chop, then make a deep trench and introduce your Sinskey hooks into the right in the center. As far as the chopping is concerned, I use purely longitudinal phaco during the chopping, and for quadrant removal I use torsional phaco. If I use torsional for chopping, I feel that that sort of reduces my hold on the nucleus bit. Break the backbone of the nucleus, multi-level chopping, gentle lateral separation, posterior plane phaco, especially during quadrant removal. Use adequate amount of dispersive viscoelastic, but please remember it's thermogenic. So I always have a small lake of HPMC in the center where my real phacoemulsification happens. Just in case you are not doing it, always evacuate a little bit of dispersive viscoelastic before activating your phaco. And beware of the weak zonules and capsule all the time, and take care. Thank you so much. Comments?
I think you covered it so well, each and every details. But for coming back to the hydrodissection, on one hand, these are the cataracts which may have a corticocapsular adhesions, and it's been stretching the capsule, and you want to make sure that there is no stress to the thinned out capsule. So we want to do hydrodissection, sure. But on the other hand, because there is no space, it's not easy to perform hydrodissection, and you are in trouble actually sometimes. And you think you might overdo it, and that procedure itself might produce some problems. So what I do is that I try one time in whatever expertise and whatever experience I have, or anybody who has done, and do it a little gentle hydro, If it doesn't work, maybe you may try again second at some other time, but don't make an issue of hydrodissection and rotation with these kind of cataract that you showed. I'm glad I'm not in Coimbatore. So do that. And as I said, do some sculpting. Again, try to do hydro, not rotate before you make sure that you have a good hydrodissection. But hydrodissection is mandatory, but it can be lethal also in these kind of cataracts. So be careful. Use your judgments.
I think very well covered. The only thing, as he has emphasized, is to have two hemisections, and often there are two things that we fall for. One is, as we try to. It's easier to trench in the periphery than in the center, but the center has the thickest portion of the nucleus. So you should always break the backbone. The periphery will always follow. So if you break the center, the periphery will always follow. So don't try to start the crack from the periphery and try to come into the center. So that is not going to be helpful. And the second thing that is there is that in case you have not been able to transact the fibers at the backbone going past the midline, then rotate 180 degrees and then go on the opposite side so that you can actually break it rather than doing a 90-degree rotation and then trying to do that. I think there's a question there, yeah.
So, sir, in the case which you showed, a couple of times I burnt my hands when I couldn't see my posterior pole, did a hydro and did a good hydro so that I could, and the cataract just sunk. So what is the way to, these are, one can always see the other eye if, there is any evidence of posterior polar, but sometimes if a posterior polar is hidden behind a brown cataract, then how do you...
No, normally when you, after doing each hydro, I would decompress and then do another hydro. So you need you can't keep on doing multiple hydros. You need to decompress the back so that you want to have the fluid wave have moved across.
No, that's not the problem. The problem is that you can't identify a posterior polar. That's what you're saying.
Not with an overload.
So basically, the first thing is the other eye always tells the story. You have to be very careful and ask that. The second thing is imaging devices. You should use an imaging device. A good UBM, as she showed, can do that. Even a OCT and Anterion will give you that. Even an IOL Master 700 can give you the integrity of the posterior polar. And if you are doing a femto, that also will give you the integrity of the posterior pole. So these are very underutilized by us, the OCT devices and the IOL Master 700. You can, I have good images. If I had the time, I would show you, but I have good images to even show the IOL Master 700 can give you the integrity of the posterior pole. So that is the only thing that is there. Apart from that, yes, it does happen. You do the fastest phaco surgery for a patient. You just do it at the...
But I think ASOCT is a must for all posterior polar cataracts today.
He's saying that. No, maybe for hard cataracts also.
I think Mahipal has nailed it. He's absolutely correct, and you must remember what he said. In our place also, if you cannot assess a dense brown or a black cataract
assume that
capsule, we do both B-scan for retina and also for the UBM. We have both. But if you don't have these modern machines and flex and all that, so in other words, do not operate on the table, do not take him on table unless you are very certain so that you can plan your strategies. So it's very important.
Any brief comment, Partha, on hard cataract before you start?
Yeah, just a very brief comment, sir. It is at times with these rock hard cataracts that the fibers of the posterior pole have not separated. So then lifting a pie with a fiber stuck can become quite difficult, but under good molecular weight viscoelastic, the pie can be lifted, and severing the fibers manually by a sharp chopper can do a great deal of importance and save a lot of phaco energy. So if those final fibers of the posterior pole can be severed with the pie getting lifted up, and that's quite atraumatic, and manually, and then the phaco emulsification can take place.
Can I make a comment here? Sometimes, Partha, these hard cataracts, we keep chopping, but center area doesn't get, divided. So sometimes what I do with the peripheral chops, you've eaten something, So slowly, lift the central area, and if you hit the central area, all the, it's like a flower pattern opening.
Yeah.
Then you can do, if you are worried, you can put a viscoelastic underneath that.
Underneath.
And break the central area with your finger.